Thank you everyone for joining us today on the 2nd of March for the webinar on Amrit Grand Challenge Jan Care program. Please allow me to share my screen. All right, so welcome everybody. So we on behalf of IKP Knowledge Park welcome you to the 6th webinar of the Amrit Grand Challenge Jan Care program. This is year 2 of the Jan Care program, where we aim to identify 75 health tech innovations and fund them, nurture them with the assistance of BIRAC and various other partners to enable new solutions in digital health, which are aligned with the National Digital Health Mission and Ayushman Bharat. For those of you who need the link to the application website, our colleagues will be sharing it in the chat box. Please do click on that when I share with you.
You're on mute, Vikaman.
Yeah. Thank you everybody for putting up with me. Sorry, welcome again to the Amrit Grand Challenge Jan Care program. This is the 6th webinar that we're doing as part of the outreach to spread the message of this wonderful program that has been set up by BIRAC in partnership with IKP and several others. We thank the various partners, Department of Biotechnology, MIT, India Health Fund, Anubhuti, IIIT Foundation, NASCOM, LHIF, Startup India, Amazon Web Services, and MathWorks. We also have a few outreach partners who have joined us in this particular program, which is PSG STEP Coimbatore, Sign IIT Bombay, Art Park at IISc. This is one of a kind, unique program where we aim to identify 75 innovations and fund them, nurture them, coach them, solutions that are in the space of digital health, aligned with the National Digital Health Mission and Ayushman Bharat. Applications are open right now on the BIRAC portal. Our colleagues will be sharing the link in the chat box, so you should be able to access the application. Applications close March 31st. The screening process will start post that, and we hope to announce the 75 innovations on the 75th Independence Day, which is August 15th, 2022. 60 innovations will receive 10 lakhs each, 13 innovations will receive 20 lakhs each, and 2 innovations in the advanced stage will receive 50 lakhs each. That's a total of 75 that will be selected as part of the program. The focus is digital health, and across digital health, we have 6 topics, which is access to primary healthcare, ensuring patient compliance, health data collection, data privacy, improved community outreach, and data-driven modeling for pharma, biopharma. So please do visit the website and fill out the application if you wish to be a part of the program. Today we have very eminent speakers who will be speaking about various advancements in the digital health space. We have Mr. Kalyan Mangalpalli, who is from the Center of Excellence, NASCOM in Vijayawada. We have Mr. Subodh Kumar, who's Partner Director at Microsoft. We have Mr. Bharat Kashyap, who's a volunteer at iSpirit Foundation. Sohit Kapoor, who's founder and CEO of Briefcase Health Tech. And Satish Kannan, founder and CEO of Medibuddy. Each of these speakers will be addressing different topics, but specific to health data privacy, storage, and security. That is the theme of today's webinar. With that, please allow me to introduce the first speaker for the day, which is Mr. Kalyan Mangalpalli. Mr. Kalyan Mangalpalli has been part of NASCOM. NASCOM was the key organizer of the Jan Care program last year. So they have a rich experience in running this program, enabling health tech solutions, apart from running various incubation centers and funding programs across the country. Right? Kalyan Mangalpalli is the director of the Vijayawada operations. He's responsible for running the Vizag Incubation Center. He comes with over 20 years of experience in GE, focused on commercializing energy transition initiatives such as microgrids, EV charging stations, wind, solar hybrids, renewable energy, electric mobility, etc. He's a graduate of electrical engineering from IIT Kanpur, and he's received the UNCTAD coveted Amrit certification for driving impactful innovation in his prior roles. With that, I hand over the stage to Mr. Kalyan Mangalpalli. Over to you, sir, for your talk and the learnings from the previous call of Jankia.
Yeah, thanks a lot, Vikraman, and a very good afternoon to all of you. Allow me to share my screen. I hope my slide is visible. Please do confirm, Vikraman.
Yes, it is visible.
Yeah, sure. Yeah, before I start, I do want to take a minute to talk about the importance of this initiative. First of all, hearty congratulations to the ministry as well as to IKP for cheerleading this effort. This has been what I'm going to speak about today is our learnings with respect to implementing the GenCare 1 program, which originated in the year 2020 in the pandemic period, and hopefully trying to see if we can adopt some of those learnings as we go across to GenCare 2, which is the new challenge that is being launched, right? As Vikraman mentioned, the GenCare 1 program was essentially, again, a cross institution effort, right from BIRAC, NASCOM, and a foundation also got involved at that point. And very happy to note today that Ayushman Bharat Digital Mission today has a fund overlay of over 1,600 crores. And I think this is something, this is a program and this is an initiative which will definitely drive the future for India. So I'll speak more about the learnings and the challenges and the opportunities in a little while. So when you look at how the challenge went, I think what you see on the screen is pretty much an overview of the GenCare 1 program, where again you had three different phases: discovery, design, as well as scale. Today we are sitting on the scale part, where a lot of pilots are today on the ground. I'll speak more about that. But overall, if you look at the number of applications that came in, about 155 odd proposals that were received, 55 that went to the jury, 53, and then 16 proposals were finally selected across various themes: mother and child care, cancer care, COPD, and cardiovascular diseases, as well as NCDs and telemedicine. So what you see on the right is is a distribution of some of those. In this program, the award was about 5 lakhs each for the lead innovator, and about 4 odd finalists also received about 2 lakhs each. But essentially, this challenge was for the last mile, was for the primary healthcare centers in those deep rural setups, which are away from, let's say, the district hospitals by over 100, 120 kilometers. In some cases, the PHCs were in deep tribal hamlets, which were even away from, let's say, the nearest PHC, right? And the hamlets were even away from the PHC. So that way, this program has been very, very important in driving the right conversations with the states. That's something I want to talk about in a little while. But overall, I would say this program very tightly fit into the whole scope and mission and the idea behind the Ayushman Bharat Digital Mission, right? Especially on the telemedicine side. So with respect to the deployment, it has been pretty much all across India. We have had pilots in Vizag, in the place where I'm sitting. We have about 2 pilots running in Andhra Pradesh, in Nagaland, far there in the northeast, in Arunachal Pradesh, in MP, then Punjab, Maharashtra, as well as Tamil Nadu and a few others, right? So again, spread right across close to I would say 8 odd states. I would say 10 odd states have adopted, or rather, these pilots are running in 10 odd states. And there was one startup which didn't fit into the whole scheme, and they're still working on regulations. So that was one part that we learned along the way. But otherwise, a lot of these have active participation and active support from the state governments. And this is one program which is really a very good model where a central institution such as DBT, BIRAC under DBT has worked very closely with the private sector and with the respective states in deploying something which is of value to the entire nation, right? And I'll talk about the learnings in a few while, but essentially this program has found really good traction and there are a lot of learnings. Each state brings its own learnings. But overall, I would say this program definitely needs to be expanded. That's why GenCare 2.0 that Vikraman mentioned is very, very important. And we need to drive more of these programs in order to understand the situation on the ground better and also to roll it out better, right? So when you look at some of the learnings, one of the big learnings has been that whatever we have deployed and whatever the idea behind the program was, that fits very tightly into the Niti Aayog Health Index. So we have seen that the states were high in terms of their health index, and they've also been the ones to adopt the solution better, right? But even the ones on the left that you see, like we have seen very good traction in the northeastern states and also in Uttar Pradesh, Haryana. We believe the more these solutions get adopted, the more they'll also move up the rankings when it comes to the Niti Aayog Health Index. I think the learning here is that as we go to the states, to the respective stakeholders, it's also important to point out that whatever is being implemented on the ground is not just a pilot for a pilot's sake. It also helps the state go up the rankings and also improve some of the primary indicators that the state is responsible for, right? Otherwise, whatever you see on the map today is pretty much, most of the states where the conversations are going, and there are a few more, at least 5 more states where the pilots are still pending, right? But they're asking for more. We're trying to see if we can get the private sector's participation and support in this. So let me speak a little bit about the learnings, and I'll end with this. I want to keep it very short. While the objective is very noble, which is to implement the digital, I would say, solutions in the last mile, what we learned through our pilots specifically is a couple of things that you see here, right? One is when it comes to compute and communication infrastructure, whether it's desktop computers, whether it's digital microscopes, when you talk of telepathology and other solutions, even smartphones, I think this is an area which needs a lot of study and also support, where when we are identifying a particular state or a particular PHC, I think this needs to be looked into. Because in our case, we had to wait for a couple of weeks, or at least 3 or 4 weeks, for even the infra to be set up, right? So I think as we go along and as we identify more, solutions to be deployed in the primary healthcare setup, I think this is one challenge that keeps coming up. But we have seen states which have taken this as a very good opportunity, and they're putting infrastructure up which can serve the rest of the programs as they come along, right? So they're pretty much setting up the base infrastructure which can help any kind of use case, whether it's telemedicine or otherwise. Second challenge or second opportunity that we see is in capacity building. We're talking about people in the primary healthcare setup who have not been traditionally into a medicine or even a telepathology or wearable kind of a use case. That's where, or even IoT kind of a use case. That's why the existing technicians, they need a lot of training, and that's something we believe is which will skill them better in order to do better when it comes to actual deployment and helping the deployment of the solutions on the ground, right? And there's a lot of change management also that needs to be done, both at the Commissioner of Health level as well as at the primary healthcare center level. The last but not the least, and the most important point that I want to address today is the SDG impact itself. What we have seen through our own deployments is each of these deployments has a very clear, I would say, tie-up or rather whatever is happening on the ground. It is clearly impacting at least 2 or 3 of the SDGs that we speak about in terms of access, in terms of reducing the incidence or catching cancer or even hematology cases earlier. And more importantly, I think this also gives a good multiplier effect, because as this solutions also get implemented and get integrated into the eSanjeevani platform of the government on the telemedicine side, we see that whatever little you put on the ground, whether it's a couple of pilots on the ground or not, it has a multiplier effect. And the state today, a couple of states are even willing to scale it across, the 2,000 PHCs, that are there in a particular state, right? So overall, I would say this program has been very useful, in building confidence with the states. And what we have seen is states have also, come forth and they're wanting to implement the latest technology. But if we address some of the challenges that we see on the screen here, I think the sky is really the limit. The intent is very noble. It requires a very cross-collaboration effort between the central state bodies such as ourselves and, of course, the private sector. So I would say as we do more of this, I think the impact would be much deeper. Last but not the least, one last point that I want to leave on the table is, I think even on some of these deployments, as these deployments go on, there needs to be also a consensus on maybe some kind of impact framework on the lines of GRI that is there on the SDG, I mean, that is there on the sustainability side. If we can also work on some frameworks around that, then each of these programs can also get tied into the framework and then get help, in scaling. When the private sector looks at investment, I think they can look at some of those registered frameworks, and hopefully that will allay some of the risks that the private sector might see in scaling this, right? So with this, I'll end my talk and leave it open for any conversations here. Over to you, Vikram.
Thank you, Kalyan. Would you like to share a couple of examples of startups from your previous call, the work that they did, what kind of impact they've had, and what would be like number one, number two challenges in terms of severity that these startups faced? Yeah.
So let me talk about the Andhra Pradesh example. That's what I was referring to. So there are two startups here. One is a telepathology one called Inventigin. They were working on, so initially we went in with a use case for cervical cancer and oral cancer, identifying them early through use of a digital microscope, low-cost digital microscope at the PHC end, and then using a pathologist who's sitting in a district hospital 100 kilometers away, right? So when we had this conversation with the health commissioner, he said, why not, expand it to even hematology, right? And that's where the real impact has been. While telepathology on the cancer side is definitely the primary use case. We have found within the little time, within the last 1 month, a couple of cases were found very early, especially on the anemia side. That's again a very huge issue with the primary healthcare center settings and with the rural settings, right? So a couple of cases were found very early using this approach where the gynecologist or the doctor at the primary healthcare center, they were able to refer them to the particular startup, and these cases were found early, and hence the intervention is also happening early, right? So these are some of the examples, that will really help set the direction for the next wave, right? And that's something that we found out. When it comes to Save Mom, again, Save Mom is a wearable startup. Initially, the idea was to put a wearable, use a wearable device for the pregnant mothers in the third trimester, right? But this being an IoT device, again, the use from the ask from the health commissioner was, can you repurpose it for even identifying the vitals, a non-invasive device that can serve as identifying the vitals for anybody coming into my PHC, because today that's not being done. So the biggest learning here is, I think you can go in with one technology, but when the stakeholder is requesting you to repurpose it, I think we should be ready and also and probably support the stakeholder in that. But today, these two pilots, I think, are having quite a bit of impact, and the commissioners is likely to even scale it to 1900 PHC. And they have put the investment in terms of the compute infrastructure. So I believe these are some of the main learnings that we have seen, at least in a couple of these pilots that I spoke
about. Thank you so much. It's nice to see some of our own IKP startups, such as Jani 3,
right.
Biodesign, Indra. All of these have been associated with IKP in the past in various programs. So yeah, nice to see. What do you did you do any kind of intervention to enable better access to healthcare centers, either on the public side or on the private side? Were there some efforts that you took that went a long way for these startups?
Yeah. So one of the biggest things that we did, and I think that's very important, is the startups speak language, right? Which is separate from, let's say, what the stakeholder on whether it's a health commissioner or whoever it is, right? Or even the district medical health officer in the case of a district. So I think what we did was sit with the startup, understand what their solutions were. More importantly, translate what they bring to the board and tie it to the goals of the state, right? Tie it to the goals of the health commissioner, whoever the stakeholder is. So that's something that worked very well, where the approvals happened in like 30 minutes over a call, even during the COVID times, right? I think that's the biggest learning, where I think one has to step in and be the translator at all times. So even today we have reviews almost every second. Yeah, so all I was saying was, I think one needs to play the interlocutor's role at all times, handhold them very closely, because this relationship can break at any level. Right? You are dealing with the the public health officials and whatnot, and their concerns are genuine. There is issues with capacity building, so one needs to play that intermediary role and ensure that at all times the stakeholders' concerns are addressed on either side, and the right goals are being met. At the end of the day, I think if the state does it well, state also moves up the health index and whatnot, right? I think that needs to be understood, that this program has very wide ramifications, and it's a national program at the end of the day.
All right. Thank you, Kalyan. We will move to Mr. Subodh Kumar. So to introduce Subodh Kumar, Subodh Kumar is a partner and director at Microsoft India. He has been with Microsoft for 18 years. He leads program management, security research, and the data center and security teams in India for Microsoft 365. Subodh was also leading the program management for Office 365, the core team in India, which included Microsoft Exchange, Skype for Business, My Analytics, and Workspace Analytics. Subodh also led program management for Office apps on mobile, driving these apps using shared code across platforms, appropriate Microsoft Office experience appropriated for each of these platforms. Welcome, Mr. Subodh Kumar.
Hey, hi, Vikraman. Thanks for inviting me. I'm going to share my screen now.
Thank you.
All right, so let me know once you start seeing the screen. Can you?
Yes, we can see your screen.
Great. So, so this is a topic which is given to me. There's one change which I'm going to do. Storage primarily also leads into conversation of physical storage, which we are not going to focus on. Rather, we'll focus more on the governance of data. That's where the regulation, compliance, privacy, everything comes in actually. So that's one change which I will do. By end of this session, I will take roughly 10 minutes talking through slides which I have prepared. My intent is to share few core use cases on which the startup, potential startup applicants who have joined this call can think of venturing, and which as a country we need. So just to start with the context, the key question is with healthcare focus for our kind of population, how are we going to manage, protect, and unlock the value which is blocked in so much of data which is there? And when we speak of data, there are various line of businesses in any healthcare system. It ranges from patient information to care team data to operational data to population health data itself. If you examine this a little bit closely, now this visual is a little bit dense, but I'm not going to read through each of these aspects. But the key takeaway here is at the core is data which is generated across this ecosystem. And around that, we need a layer of security and compliance, which then supports experiences which there are other startups who are building, which is focusing on patient engagement or empowering health team collaboration or improving clinical and operational insights. And there are other line of business also. And around that, there are various categories of applications which is there. This is a representation which I picked up from our Microsoft Cloud for Healthcare, which is built on Azure, just to make a point that there are various healthcare focused functionality which are working across the ecosystem, which is generating a lot of data actually. And to put a color into this, a typical anatomy of data is it gets created, imported, or modified in various line of business, which is sitting in cloud, or it is in various endpoint systems like mobile or desktop. There are legacy systems which a lot of organizations are using. And then that data need to be detected. Detected primarily means where the data is living actually. And once it is detected, then you need to, the need here in healthcare system is to classify and label it so that we know which data is sensitive and which data is not. And then once we have this kind of information, then we do two things actually. One is we protect data based on policy, and that's where governance starts coming in play. And second, we start managing privacy of data based on policy. These are two policy-driven things which kicks in. Then the transit happens because one is staying in an ecosystem of various healthcare partners. So you will start sharing, moving data from one system to other system. And in the process, you will monitor who is accessing. You will like to track its audit information. And then primarily, you will do retain, expire, delete. Just take an example. There are few healthcare records. One is supposed to retain it for a year, 3 years, 7 years, like that. And this is by law actually for different purpose. So if you examine a data life cycle in the context of various core use cases, this needs to be applied at rest in transit. It needs to be supported across heterogeneous systems and in compliance with regulations and policies which that business organization is having actually. Now, this entire thing needs to be supported across this ecosystem. And this is a visual from India government ecosystem. This is how they describe it. And our country needs right now solutions which are focusing on privacy, governance, and protection when data is moving across this ecosystem from one entity to other entity actually. So that multiplies complexity for the innovation which we can do. Now, to sort of sum it up now, I'm going to list a few core use cases in which you can consider thinking of doing innovation to help this vertical or domain. So one is around information governance. Information governance primarily implies retention, archiving, access, those kind of solutions. And imagine when data is moving from various ecosystem entities through sharing itself, that is where the scope for innovation comes in. And from a technology standpoint, there are startups and there are innovations which are focusing on blockchain. They are doing encryption. They are doing encryption, rather classification on encrypted data at a scale actually. And there are all sort of those opportunities which exist in this first bucket itself. The second bucket is all around protecting information, which is how can I ensure sensitive information is classified and protected wherever it goes. So there are three challenges here which are very unique to healthcare, given the ecosystem play and the very nature of data which lives. One is sensitive information. How do you detect where sensitive information is living and you are able to classify it? Classification also traditionally is done using a dictionary sort of thing, like there are sensitive types and you match it, and if it is matched then you label it as that classification. But then there's a lot of ML usage which is there, and if you combine with vernacular language which is used in our country, there is enormous opportunity for innovation there. The third aspect to this is wherever it goes. Wherever it goes is very complicated challenge because data is flowing from one system to other system. There is no perimeter there. So how can you ensure the classification information or the classifier itself is sitting along with data so that it gets respected? It's all the policies and encryption are respected wherever that data goes. The third is around managing privacy. So once we know which data is what, then you need to enable privacy. And this is, you can imagine this more as a layer which is sitting on top of data which is already classified, and we know which data is personal private and which data is not. And there is a policy to dictate that. So primarily focus of this innovation is more to track all the data subject requests which regulation is asking for. Like in India, PDP is coming up, which will make it mandatory for having this in place. And this is applicable for both employee data and customer data for when it is in use or when it is shared, actually. The sharing part makes it, again, complex, and hence innovation will use some deep tech there. The third piece is around managing insider risk. Now, this is a little bit more, I will say, advanced use case. When you are able to classify data and when you have build a layer of privacy and other solution of protection, etc., then comes the need that is my data safe and is it being leaked or stolen? And that's where there are the solutions, there's scope for this kind of innovation one can do to track suspicious or malicious insider versus negligent insider. And again, there are ML models one can build to generate it. Now, this one again becomes tricky if you bring in vernacular language and various communication channel which people can use to take out data, like somebody is doing steganography, which is very advanced form of insider risk, versus somebody is taking an image, versus somebody is sharing it over WhatsApp, etc. So that creates interesting innovation scope. The second last is data investigations. These are typically solutions one builds when there is an incident and you are now investigating. So that's where you will look for audit trail in the system, who has used when, and you would like to create a complete forensic around it. And there are those solutions required in any such breach case. And it supports the security breach side scenario also, by the way. Typical cybersecurity attacker breach side. The last piece is around compliance. There are a lot of regulations in play for which is enforced only on data, beside user and other things. And PDP is one such example. GDPR is a more famous example globally. And this is where organizations or healthcare institutions, they would like to continuously monitor. One thing to understand here is this is not only about regulatory compliance, which means law of the land compliance, but it is also to enforce policy compliance, which that corporate or that entity has in place. And for both, you would like to have an experience to do that. So these are, I thought I'll share it. The 6 categories of use cases you can consider focusing your innovation around. And with that, I can take questions.
Thank you so much, sir. Thank you. Do you have examples of startups that have come to you, worked with your platforms for scale, while deploying? Have they chosen to work with you, and how have you enabled? Do you have a couple of examples that you would like to share?
Yeah, so there are many such examples. Like one example which I'll pick is in an Indian context. So there is something called as differential privacy. So differential privacy is of a lot of use in the healthcare ecosystem play, where you don't want to share individual data, but you want to see pattern of data which is arrived at a group level. Like there are a group of people and you want to share that level of data. So for that, one can use blockchain when that kind of data is being shared between, say, 2-3 different organizations. And that's where people have opted for Microsoft Cloud to build that for scale. And when I say scale, I've seen another thing, and for that purpose, I picked an example, and I'll just share it to make that point. So if you see this this visual, which sort of paints an architectural diagram, and I'm assuming people who are founders or potential founder, they'll be interested in this kind of example detail. So this is an example of protecting information for a functional use case where prescription claim management and automation is to be done. What it primarily means in simple English is to make handwritten prescriptions actionable with a high degree of confidence and accuracy. Now, this is a common problem. A lot of startups are already focusing in India and globally. And for this, what is described here is a sort of technical architecture using cloud. And I'll make few points, and that's why I thought I will pick this as an example. So any cloud like Azure, and I'm using Azure as an example, you can think of same thing in Google, Amazon, and other cloud service provider as well. These are two sources. Now, as a innovator or as a startup, your focus is primarily going to be on this box, which you see here, custom vision prescription classification, because this is where your IP exists. Rest of the thing which you see as an example, this Azure Cognitive Search is also the place where an IP is going to sit. So these are two places where the classifiers or the intel which you're designing for the target market which you are picking up, you are defining. And once you define it, the rest of the architectural components help you grow from a design partnership to piloting with few customer to and then scaling actually. And that is how you can scale. And this is what we are seeing as a pattern. A lot of startups are doing with our cloud actually.
Thank you so much for sharing that, sir. We are actually in touch with your team to partner with Azure. We are hopefully that will close soon, and we will be able to introduce these 75 innovators to Microsoft Azure as well. And hopefully we can work together as these teams put out their solutions in the field. That discussion is actively in progress. We will keep you updated, hopefully. That happens. If audience has any questions, please do add that in the chat box. We'll be happy to take the questions and present it to the speakers. So I think at this time, there are no further questions.
Okay.
So if you are here, then we will, I guess there'll be another round of questions after the other speakers have finished their session. Otherwise, we will send you the questions via email and get back to the participants. I hope that is okay.
Yeah, happy to take questions offline. I might drop after 15 minutes.
Sure. Thank you so much. Thank you so much for sparing your time and coming and presenting at our webinar. We hope to stay in touch with you and bring all of these innovators to Microsoft once the selection is completed.
Thank you.
Hi, sir. Thanks, everybody. So with that, we will move to our next speaker, which is Bharat Kashyap. Bharat Kashyap is a volunteer at iSpirit Foundation. iSpirit Foundation is a think tank that has been assisting various departments in the government, addressing various industries with policy papers, especially in the fintech space and also in the healthcare space. Bharat is a volunteer and part of the Public Health Records Working Group, crafting the design of the unified health interface for telemedicine. Is also part of DAPA 2.2, working to create the next generation specifications for India's data empowerment and protection architecture. So when there is healthcare data, there's a lot of concern about privacy, about how much you want to share, whether you are able to give consent, is it a time-based consent, etc. So there is policy, and then there is a software stack that helps you implement this in a standard manner across the country. So Bharat has been working on that with iSpirit Foundation. With that, I request Bharat to share his presentation and walk us through the work that they're doing at iSpirit.
Can you see me?
Yes.
So I have a very minimal set of slides, I think. Okay, to interact with it for a bit. If you could just type DEPA in there, and just like click on, just make the Google search. Just escape and do, yeah. All right, so hello everyone, I apologize for that issue. My name is Bharat, I'm a volunteer at iSpirit. I'm a part of the DEPA working group. And the theme of my talk is DEPA for digital health. And I realize not everybody, in fact, probably very few people know what DEPA is. So that's why I have this Google search so that everybody can find out that DEPA stands for Data Empowerment and Protection Architecture. And there is a very comprehensive report by the Niti Aayog on the subject. There's also there's a lot of research on how it might transform the Indian financial landscape but very little has been said on the impact that DEPA can have on digital health in India. And therefore, the aim of this presentation is to make, Vikram, if you could go to the next slide, is to make via the arrow at the bottom. Yes. So to make a technological, but also a political and economic analysis of the evolving digital health stack in India, and to see how DEPA fits, the next slide, how DEPA fits into the center of this star, that is the situation, the tasks, the action, and the results and the roadmap. So to begin understanding DEPA, next slide, therefore it's key to understand the situation that led up to its conceptualization, specifically the situation around technological service delivery in India. In India, service delivery was the domain primarily, in fact, almost exclusively of the government. The 80s was the decade when this service delivery started to become, next slide, started to become technological through computerization. So if there was a paper-based application form for a particular service, next slide, if you could, it was now available in a way that could be edited and updated via a computer terminal. Now, this was followed by the digitization of the service delivery in the next decade. So now perhaps you could download an application form via the internet, partially fill it, and then upload it. Although you would still eventually have to visit a government office either to prove your identity or to make the payment and so on and so forth. Now, in parallel, there was a model that had come to dominate the world at the time. And this is summed up very well in a speech by Peter Thiel, who's most famously the founder of PayPal at Stanford University, called Competition is for Losers. In the beginning of that speech, he talks about the potential of service delivery, and in particular, service delivery through software, where he makes the comparison between airline businesses and Google, saying that while intuitively it seems like airlines deliver a more important and more valuable service, that of physical mobility, Google has more market capitalization than all the airlines put together in the history of the world, simply because they're able to build once and deliver infinitely many times. The underpinning idea being that technological service delivery happening through businesses is a key pillar of the economy. But the more important idea, which he gets to subsequently, which is what the talk is named after, is that anyone aspiring to build a business must aspire to build a monopolistic business, because competition is for losers. In fact, somewhere in the middle of the talk, he says that innovation, which is how society moves forward, is a byproduct of competition, and giving the example of scientists who lose the value that could have been captured from the research that they give away, he says that the winners are in turn the businesses that grow to become so dominant that they don't have to compete. What clearly emerges from, and what we can see here, what clearly emerges from this is that there was a spectrum of monopoly, where on one hand, we have this model of governmental monopolies on service delivery. And on the other, we have this idea that services are to be delivered by monopolistic businesses. And therefore, intuitively, it becomes clear that there is a space in the middle, at least theoretically, where we have this sweet spot of societal value getting created through competition, while simultaneously we have multiple businesses that are able to thrive. If you grow, yeah. In fact, this theoretical sweet spot is not just imagination. There is a substantial economic theory on the subject that even got its creator, Elinor Ostrom, the first ever Nobel Prize in economics to be awarded to a woman, for the excellent definition of the concept of public goods. The two metrics she defines being non-excludability, which is that a good whose usage cannot be denied to anybody specifically. And we've seen over the past few days multiple examples of excludability. But to me, the most intuitive example of a non-excludable good is a street light, where once it's turned on, there is no way to deny its usage by any particular person. And the other metric is non-rivalry, which is to say that the usage of a good by one person should not diminish its availability to anyone else. And the greatest example of this, to my mind, is free and open source software, which can be produced once and used by infinitely many people at the same time without diminishing its availability to the next person. As we move forward, free and open source software really became the bedrock of this idea behind digital public goods. And in fact, there's a talk by Jim Zemlin, the director of the Linux Foundation in 2013, which almost is, if you can stay on that slide, which almost is a competing talk to the one by Peter Thiel, which I mentioned earlier, where he presents, in fact, a graph of the shareholder value delivered by Red Hat, which is an organization that exclusively sells support for free and open source software, and the shareholder value delivered by Microsoft, which at the time was a very hard believer in closed source and closed hardware models. Of course, they made a very drastic turn in the next few years when the leadership changed. where Red Hat had actually delivered more shareholder value in the preceding 5 years. So the story simply was that doing good can be good business. And that story really inspired the creation of public digital infrastructure in India. And if I am to extend the story of the application form, if you can go to the next slide. From earlier, now it's possible to not just apply for these services, but to complete those applications, verify identity, pay for services and bills, get support, all of that through innovative businesses that have come up over the past few years. To make a railway analogy, the businesses are the platforms serving diverse needs of a vast population, and the rails are the public digital infrastructure for identity, payments, and storage that we're all now familiar with. Now, to move to the second arm of the star that I spoke of earlier, the action that we all needed to happen was the creation of these rails for the flow of data. And that is what DEPA really is. You can go to the next slide. Yeah. It's a protocol with 3 principal entities. And to explain it in the domain of health data, we call them the HIU. Next slide. So the health information user, the HIP, the health information provider, and the CM or the consent manager. And the idea being that the patient, you can stay on that, yeah. The patient is the owner of their data, and the protocol allows for the flow of and only of consented data. This consent is sought, handled, and managed by a consent manager in the middle. And the patient is allowed a choice between multiple consent managers, multiple HIUs, and of course, multiple HIPs, while the data remains interoperable across all of them, which is how an ecosystem really gets built for digital health in the country. Go to the next slide. Yeah. Now, the result of such a system, and I want to speak primarily from the principal outcome, because there's multiple second order outcomes that we will see, and perhaps speakers will talk about in the succeeding speakers. But the principal outcome is the reduction of the cost of trust in healthcare in India. And as a seeker of healthcare, what really is the trust that's needed in the industry at present? It is 1, next slide, can you pay for the service? And 2, what is your medical history? Now, of course, the first question might seem to be a financial data problem, right? Can I make a prepayment through UPI to prove that I can pay for this service? Or can I make a UPI mandate to prove that I will pay for this service? Can I share my bank account data to prove that I'm able to pay for this service? But if we zoom out a bit, we'll realize that this is also a health data problem. Am I an Ayushman Bharat beneficiary? Am I serviced by another health insurance policy? Is this health insurance that I'm trying to claim, does the health service that I'm trying to claim, is it offered by my health insurance? There is an immense cost of having to prove all of this at present, and the consented flow of health data has an equally immense possibility of being able to wipe out this cost. And almost exactly the same cost of trust exists in proving your medical history, where we need a better alternative to carrying around CT scans and X-rays, which I had to do during the second wave of COVID, even for my own parents. And I think everybody can relate to how difficult it can be. And I'm sure other speakers who will follow me will talk about this exact same problem. So the solution that we're trying to build is the PHR protocol, which will allow all of the entities in the digital health economy to communicate whenever they want to share or access new data, be it medical history or consultation history or even insurance status. There's infinite possibilities, all via consented flows of data. Of course, the ecosystem is getting rolled out as we speak. The specification is evolving. I've linked the currently published version on the Ayushman Bharat Digital Mission Sandbox website. So I'd ask people who are watching this to engage with it and offer critical feedback, which can go into the updates that will happen as this keeps evolving over the next few months and the next few years as well. And finally, before I end, I want to speak about the roadmap. You can go to the next slide. Yeah. The short-term future of this, of course, is the emergence of a digital health economy in India with multiple platforms, all being serviced by public rails in the forms of protocols. One other longer-term objective behind DEPA is also focus on data availability for research. And I think the previous speaker, he mentioned a lot on classification and machine learning. We've made some strides in data availability for research purposes in the past few years, starting from RTI, where government data started becoming available for the first time to people, to now we have this open government data platform where the government frequently publishes data in a digitally consumable form. But the situation in making data available for research is not the best in our country, of course. We did speak to some health researchers in the UK as well, where they spoke about how they have a system where an individual can request the National Health Service of the UK for data, or even ask them to perform operations on that data and share the results back with them. We do need similar good data availability for research, but the idea is that we need it on a higher frequency basis and in a shorter loop. That really is where we see the long-term future of DEPA in digital health in India, where these rails allow access to consented and ethical access for researchers to the health data that they need to really accelerate health research in this country. And I'm sure there's a lot of innovation that will happen on privacy-aware data sharing and governance for this purpose in the future. And that's really it from me. Thanks for hearing me. And I'd be excited to listen to any questions right now or even later. Thanks, Vikram, for your support.
Thank you, Bharat. That was a great presentation. So we have a question from Bhibu, which is, can you give an example of published digital data, health data that's already available for people to access?
Right, I think, so he's asking for public data that's available in the department or public health digital infrastructure. So I'm assuming this, the question is about data that's already available.
I guess that is the question.
So I'm not exactly aware of all the health data that's currently available because I'm not a researcher of health data, but I'm sure if we go to the platforms of the government, specifically the OGD portal, we'll be able to find a number of sources of data that the government has started publishing on public health in the country, specifically about the implementation of multiple centrally sponsored schemes, for example, the number of healthcare centers that have been created under multiple schemes and so on and so forth. So that information is available if they want to access it under the open government data platform. But really that question is what we want to answer with data availability in the future, where it's more higher frequency data is available to researchers, not necessarily provided by only the government portals, but through multiple other platforms, multiple other forms.
There's a follow-up question from Pallavi Sankhe, which is, what should an innovator ensure while designing a system architecture in order to comply with the unified health interface?
Absolutely.
Are there any published guidelines on the same?
Yes, so I think the one that I shared in the slide, that's really the one that they need to follow. There are specifications on every single entity in the ecosystem if you want to be a health information user or a health information provider. So there's a link in the slide. The slide itself is available on this website. You can go there and you can access the link. So I'll share the link as well in email or on the chat as well if somebody wants to. Yeah, so just do access. And the specification is obviously evolving basis the feedback of the participants that are already in the ecosystem, and it will keep getting evolved and we'll publish newer versions. But currently, these are the guidelines that a interested participant should comply with.
Okay. All right. Thank you so much, Bharat. I think that was a great talk. Thanks for introducing me to GitHub's presentation modules. I wasn't aware of this. So with that, we have a couple of startups who have joined us today to present their stories. The first one is Briefcase. We have Sohit Kapoor, who's the founder of Briefcase, with us today. So, welcome, Sohit. So Sohit is the founder of Briefcase. He was with Merrill Lynch for over 12 years post his graduation from IIM Bangalore, and then started Briefcase in 2016. Briefcase is now India's first integrated public health records app with health locker capabilities for the Ayushman Bharat digital mission approved by the NHA. Using the app, users can create their own Ayushman Bharat health application. I don't know, I don't know what ABHA stands for, but ABHA address and manage sharing of health information with doctors and other health service providers within the ABDM framework, and also manage their health records within the lock. Over to you, Sohit. Please do share your screen and walk us through your presentation.
Sure, thanks, Vikraman. Thanks for having me here. What I decided to do was take a break from presentations for everyone and talk through our story. So, in your introduction, you've covered about Briefcase. Let me just touch upon a couple of aspects there, and then we'll go through the story, our journey at Briefcase. As As you mentioned, we are a personal health records app. What does a personal health records app do? It allows users to make their Ayushman Bharat Health account address. This is the address similar to the UPI address. So in my case, it is, let's say, Sohit@NDHM or Sohit@ABDM as it will become. It helps you manage your consents. Bharat spoke about the whole consent manager. So this is the front end, the user side platform of the consent manager. So you can use the consent manager app to approve movement of health information from the HIPs, the health information providers, to health information users. And because we have an integrated health locker or a health vault, you can manage all your health information at one place. So that's what Briefcase is. We are the first PHR app to go live under the Ayushman Bharat Digital Mission. We're seeing, as the previous speakers spoke about, we believe that Ayushman Bharat Digital Mission will change the face of healthcare in India. It will help not only accessibility, but will also help the affordability aspect of healthcare, and will truly help us achieve the universal health coverage dream that we as a nation have had for many, many years. Our journey has been a bit long. ABDM is a good culmination or a good milestone for us, as we put it. But we actually started way back in 2016. My founder Harsh and myself, we both from Merrill Lynch background, launched Briefcase as a personal health locker, a platform which could help users manage their medical records digitally. And this was at a time when ABDM or NDHM, the earlier avatar of ABDM, was not spoken about. The idea behind Briefcase has been that everyone takes care of their health. Very few people take care of their health records. And again, Bharat mentioned about UK, that NHS has all your health information. And if I have to draw parallel to US, in the US, your insurance payer decides your health journey and becomes an aggregator of your health information. In India, you as a patient, as a user, are the only aggregator of your health information. And that's what we wanted to target. So the platform was a very simple concept, one place where you can have all your health records, managed seamlessly. We went around speaking to people, and it was a concept that was loved by a vast majority of them. It's not that health locker, we were the first health locker around. There had been few attempts earlier as well. But in vast majority of the cases, these health lockers were just one of the functionalities offered by larger organizations, if we can say so, where the core functionality was something else. Could be offering medicines, could be offering lab tests, booking platform, or something on those lines. And a locker was one of the many features that get bundled in. In the true sense, we were probably the first to offer this as a product, as a standalone product. We spent 3 years post the launch, building this category out. And as I mentioned, as a concept, this was something that was loved by one and all. But we saw that there was a vast gap between loving the concept and adopting it. And that's what, when I say building the category, that's what our focus has been on. The biggest challenge that we saw in this gap between loving the concept and adopting it was user inertia. So I want to have all my medical records on a platform. I'd love it that way, but I just don't want to put in the effort, or it becomes too much to get all my information on the platform. We spent a lot of time streamlining the user journey. Gave them multiple ways of uploading their records. Just email across the records, click a picture and upload. We even have home scanning services and courier pickup services, all with the single objective of making it easier for you to get all your health information on. And once the health information is on, how can you seamlessly access it? We've all gone through a very tough last 2 years, where you realize that when you're looking for a health record, it's not usually a stress-free situation. It's usually a situation where you are facing multiple challenges, and in that, the last thing we want is to spend minutes, hours, or days to find a record. And that's been our second promise to our users, that they can find any health information, any health record in less than 10 seconds. So this is how we managed to achieve usage, and there've been some good numbers backing this for us. On an average, an active user of Briefcase has more than 25 records on the platform. About a sixth of our users have records spanning more than a decade of their life. And these are matrices we kind of track to give us the confidence that we are on the right track in our objective. Along the way, we spoke to a lot of doctors about this concept, and again, concept was light, but what we realized is doctors themselves were very thin as far as digitization of health was concerned. They themselves needed solutions which could help them in their journey, and that's where we launched our clinic management product. Now that again is a product is something which is quite well understood in the market. We built a product which was highly customizable because what we've seen is that a lot of times the tech people that we are or the business people that we are, we try to change the behavior. And with doctors, that's challenging. There's a certain way they've been working for many, many years. You can't always expect them to, change their working style. And that's where this level of customization was built in to essentially give them the space to work the way they've been working, at the same time achieve the objective of digitization of their practice. So that's been our second product out in the market. And then in this journey in mid 2020, we connected with the iSpirit team. And we had a discussion around ABDM, and it was called NDHM in those days, as to what was happening on that front. What we realized is that a lot of work had been done on the NDHM, and but largely speaking, that was focused on the provider side. The consent manager was very well defined, and there was a health blocker actually as a separately identified entity in the whole framework, but that was not yet fleshed out. So that's where we kind of partnered with the iSpirit team and provided our inputs on how the locker journey could be defined from a user's perspective. Very, very happy to see that the locker, as it came out in the NDHM, was on the lines that we had discussed with the iSpirit team. Once the NDHM was made, the sandbox for NDHM was made available, we very quickly kind of got into that, built out our solution or integrated our solution into ABDM, and were the first health locker to be approved under the ABDM framework. Subsequently, we've taken that product forward to, as I started my conversation with, to become India's first personal health records app, along with an integrated locker. So that's been our journey. It started with a certain objective. Along the way, we've had multiple stakeholders. We've had conversations with multiple stakeholders, have figured out what their requirements are. And then there came this big moment of the Ayushman Bharat Digital Mission, which was a tremendous opportunity for us to kind of partner in and make our solution even more relevant to the times. So we'll take a pause here with that. Happy to answer any questions or anything specific that anyone would like to discuss.
Thank you, Sohit. So here's a question from Bipu again. Now in India, do all health records are all health records available? I'll just rephrase the question. Are all health records available in an app like Briefcase? Or is there some other website? Is Briefcase associated with a particular disease, or is it diversified to all types of disease?
Sure. So the way the Ayushman Bharat Digital Mission is playing out is, Bharat used the term health information provider. So all your healthcare providers, be it labs, clinics, hospitals, or any other platform which generates health information for you, needs to integrate into the Ayushman Bharat Digital Mission as an HIP, as a health information provider. Once that happens, then the records created by that entity are discoverable. Mind you, there is privacy by design as a part of this framework. So discoverability doesn't mean that anyone can access those records unless until you as a patient specifically consent to it. But once they are discoverable, they become available to the patient certainly. And the patient can go to any platform like Briefcase, which is a personal health records platform, to access them for herself or himself. Today, Briefcase is the first PHR app. A few more players will come out in the market, and then there will be the health information users who could be again your other care providers, insurance companies, and so on and so forth, who, if they want to access this information, can take your consent to access the information. So that's as far as how the health information is available in the market today. Providers have just started going online on ABDM, but we see a huge flow happening over the next 2 to 3 quarters. So you'll start seeing increasingly more and more bigger names coming to the market, and then even the smaller providers will plug in. The second part of the question regarding whether we are specific to a disease or diversified, we are not specific to any disease. We are aligned to the patient, to the user, and help the user maintain her entire medical file or all her health records onto the platform.
Okay. Thanks, Sohit. So just another question. So I think recently there were articles coming out that UPI is beating MasterCard in India in terms of the number of transactions. When do you think half of India, or at least all the smartphone users of India, how many years do you think before everyone has an Abha account and everyone is transacting on this platform?
Sure. I think this will require some amount of crystal ball gazing, but a few data points here. So if you see the latest weekend news, the cabinet has approved allocated 1,600 crores for the creation of health IDs for the next 5 years. If the question pertains to smartphone users, I would say that this would be significantly faster than how UPI also progressed. And unlike UPI, where a couple of black swan events played out to propagate the adoption, here there are use cases being built on top of the ABDM. And again, Bharat spoke about the UHI framework and other initiatives that are being taken. So, if I were to stick my neck out, I'd say much faster than UPI. So I'd say probably next 3 years.
Okay. That's wonderful news, and hopefully this is a platform that can be taken forward to other countries as well. For example, one of the digital health companies that IKP supported is Everwell Health, which has now deployed the solution across India and has lent the solution now to Myanmar, Cambodia, Afghanistan, and a few African countries. So hope to set the standards and infrastructure settings for the rest of the world. Thanks so much, Sohit.
Sure, thanks a lot.
With that, I'd like to introduce the next speaker, Satish Kannan. So for now, if you've noticed, and Satish is the last speaker for the day. So the first speaker from NASSCOM spoke about the program from last year. And then we had Mr. Subodh Kumar talk about the infrastructure that is available for digital health startups. Bharat spoke about the policies that are coming together. Sohit demonstrating those policies that have been developed in India. And then finally, Satish, who's an example of a scaled digital health solution across India. Satish is from IIT Madras. He started out developing a medical device, but then pivoted to setting up what was DocsApp, and now it's called MediBuddy. MediBuddy is a Series C funded startup, one of the best cashless healthcare providers in India. MediBuddy allows you to do pretty much everything from doctor's appointments, ordering medicines online. These numbers may be wrong, or these numbers may be old. They've completed over 13 million consultations. They have 90,000 doctors, 23,000 PIN codes served, and more than 3 crore Indians served through the platform. MediBuddy just recently raised a $125 million round. So Satish, your advice to the aspiring innovators on how to build scale and how to build secure systems while you're building scale. Over to you, Satish.
Thank you. I think it's a pleasure to meet all of you guys today. I'll quickly share my presentation. This will be a quick one, and then happy to take any questions that. Okay, good. So that's sort of the quick background about us. This was a little about the journey, right? So today, as a company, we sort of started in 2013, and we actually started with a team of 6 people. I know Vikram since those days, and I and Inba is my co-founder and my classmate from IIT. We started there, and of course, we've been consistently scaling and growing. And the key has been how many patients are we able to help every day, and that has been the key metric. It started with helping, let's say, 1,000 people every day. Today, we are helping around 35,000 people on a daily basis. And over the scale of the course of time, the amount of raise that you do is increasing, the number of team members increase. But the most important point being, how many patients are we able to help every day? And I'll tell you the context also in some time. And this is across the spectrum, right? So what all we help them? So we help on a daily basis around 35,000 patients. Because it's a technology platform, you need to have partners. Because it's a technology platform, you need to have partners. So we have around 7,000 hospitals, 90,000 doctors. We have diagnostic centers. We also do annual checkups, which means somebody wants to do a full body checkup. We help that. Medicine delivery across the country. We also have pharmacies or people who can actually go pick up at the store. As I told you, it's an omni-channel approach. If you want somebody to be delivered to your house, they'll get delivered at your house. If you're okay to book on our platform and go pick it up from the center, you can also do that. And we also have what is called as integration into multiple partners on one side, but at the same time, the integration into top corporates benefit. We are actually integrated into a company, and for whatever is sponsored by the health company. Example, companies also sponsor COVID vaccinations. So in all those cases, you would come and access the service, and the bill will go to a company. In case you have a health insurance policy into Medibuddy, and if there are benefits that is there in the policy, you can actually directly use them also very easily through the platform. Yeah, so now this actually, if I'm on the right slide, you'll be able to see India map, and what it essentially means is these are the locations of patients who use our platform. So you can see there can be dots all the way from Jammu Kashmir downwards till Kanyakumari from the left to the right, right? But the point to note here is the doctors are in the big cities. And what happens now, this clearly showcases that the only way we could have done all of this is by a company in a digital way, and definitely not by the physical only approach that was previously happening. And this actually gives us immense pleasure, because the way we have done this is also because by ensuring that we go all of this through regional languages. So one of the important things about scaling is when you start, you have a couple of customers who come in. It's very easy to answer their questions, manage their health issues very easily. But once you start scaling, you need to understand that, okay, India is a country, not all of them would understand English. So we actually launched our application multiple languages, as well as you can talk to the doctor in all of these languages. Somebody would be able to express his health problems very, very easily or comfortably in his mother tongue. So somebody wants to talk in Tamil, Malayalam, Kannada, Telugu, Hindi, Marathi, Bengali, all of them. So we support all of these languages, and that's another key reason why we have been able to scale not just in the big cities but also in the smaller towns. We also have multiple products. The key product that we also sell and which brings in a lot of customers is what we call as a Medibuddy Gold program. Now, this is another important thing from an affordability point of view. So what Medibuddy Gold does is, in case you buy Medibuddy Gold, you will be able to use online doctor consultation unlimited number of times. It's actually unlimited for the full family. So family roughly is 6 people. I think about, let's say, husband, wife, 2 kids, and then and this also gives us a lot of data to give insights back to the customer about the health history. Of course, we collect all of the records and sort in certain formats, the relevant formats, but more importantly, give insights to the customer about the health issues and how it has progressed over many, let's say, many quarters or many years, for that matter. To summarize all of this.
So Yogita, what we'll do is we'll compile the questions, and we'll probably do another call just one-on-one with Satish once he's back in his office or back where the connection is good, and then we'll append that video and post it if that's okay with you.
Sure, Vikram, we can definitely get that done.
Okay.
Apologies for all the network issues.
Vikaman,
Yeah.
sorry for interrupting. At least she can tell us the 3 challenges, the question which you asked. If she can answer, it would be good.
Yogita, do you want to take that on, or?
I don't think I'm the right person to take that up.
Okay, I'm sorry.
I'm really sorry.
No worries, things happen. Hopefully things will scale later.
Sure.
So, yeah, so no problem. So I guess that's the set of speakers that we had for the day. Thanks, Satish. We will come meet you in your Bangalore office soon once you're back.
Yeah, please.
So you're back, so we could hear you. So 3 challenges. Would you like to talk about 3 challenges? Okay.
Yeah, I think outside the internet challenge, I think let's find out 3 more challenges. Hopefully this internet stays through. So what I was trying to say was, one, see, it's multiple things, right? So first we need to work with the customer, which being the patient. Like we know, right? Healthcare is all about trust. Gaining the trust of the user is one of the most important problems to solve. And as a customer, when he started using it on our platform, they would ask many questions about who's the doctor, can we do it online, what can be done online, what cannot be done online, then the protocols around it. You need to work with the doctors to convince them that, hey, this is doable. Of course, it is true that COVID accelerated in the last 2 years, but before that we had started, of course, way back in 2015 when we launched the full solution. So one is understanding the customer and then working with him to build more trust, and hence accessing doctors in multiple languages, regional languages support. So all of that is like one part of the ecosystem. The second thing is
Okay, no worries. In the interest of time, let's introduce the next session. The next session will be on March 4th. And the theme of that discussion will be solutions to enhance patient compliance. We have Dr. Ambut Chaturvedi from IKP. We have Mr. Sumnesh Joshi, who's the Deputy Director General from UIDAI. We have Dr. Manas Panigrahi and Dr. Subhash Kaul, both, I believe, from KIMS. Dr. Manas is a neurosurgeon and Dr. Subhash is a neurophysician. We have Dr. Sai Praveen Haranath, who's a pulmonologist from Apollo Hospitals. Dr. Ananta Krishnan, Senior Program Officer at the Bill and Melinda Gates Foundation. And we have Andrew Cross, CEO and founder at Everwell Health, also called 99 Dots. With that, I thank all of the participants for taking the time out to attend the session today. I thank all of the speakers, Mr. Subodh Kumar, Bharat Kashyap, Sohit Kapoor, Satish Kannan, and Mr. Mangalapalli from NASCOM for taking the time out and presenting to us today. We hope to see you all on March 4th at 3:30 p.m. Goodbye.